Today we'll talk about infection of the genital and pelvic organs, including STI. What we'll cover today: first is vaginitis, next is cervicitis, and bacterial vaginosis, pelvic inflammatory disease, peripheral infections, genital tuberculosis, and sexual transmitted infections. The vaginal environment, the vagina dynamic ecosystem with 10 to the power 9 bacterial colony forming units. Normal vagina discharge is clear to white color, odorless, and of high viscosity. The lactic acid that will be helps to maintain a normal vaginal pH of 3 point, uh, 3 point. Okay, the normal vaginal maintain the lactic acid helps to maintain the normal vaginal pH, that is 3.8 to 4.2. Acidic environment and other host immune factors inhibit the overgrowth of bacteria, so you have to maintain the acidic pH of this vagina. That will prevent all the infection except candidiasis. Some lactobacilli also produce hydrogen peroxide, that is a potent microbicide. Normal bacterial flora is dominated by lactobacilli and other potential pathogen present. Common causes of vulvovaginitis: one is candidiasis, one is trichomoniasis, another is bacterial vaginosis. Candidiasis typically thick cuddy white discharge. Trichomoniasis you will get greenish yellow frothy discharge. In bacterial vaginosis, gray white homogeneous discharge. Okay, these are very important things you have to differentiate. The clinical presentation of the and symptoms of bacterial vaginosis: the bacterial vaginosis usually occur due to alteration in the vaginal flora from lactobacillus dominant flora to cocobacilli dominant flora, that is Gardnerella, vaginalis, mobilincus, all these bacteria. Usually they are asymptomatic in 50 to 60% of cases. Signs and symptoms: when present, they will malodorous, fishy smelling of vaginal discharge, more common after the coitus. Bacterial vaginosis diagnosis using the Amsel criteria. The Amsel criteria, at least 3 out of the 4 findings. One is the vaginal pH has to be more than or equal to more than 4.5. Presence of more than 20% per high power field of clue cells on wet mount examination. Positive amine test or whip test. Homogeneous non-viscous milky white discharge adherent to the vaginal wall. Very very important. Homogeneous non-viscous milky white discharge that is adherent to the vaginal wall. Then Gram-Stein for bacterial vaginosis, the new gen score they are using. The score is how to depending on the organism morphotype, they are giving the organism morphotype and the number of bacteria in oil immersion field. They score 0 to 4. For lactobacilli morphotypes, the number of if they get more than 30, that is score 0. Because lactobacillus is more, then it will be score 0, because it will not cause bacterial vaginosis. It is a protective bacteria. It will cause lactic acid production that will help it to prevent all this, maintain the acidic environment, all these infections. So 5 to 30 is score 1, 1 to 4 is 2, less than 1 is 3, and if there is 0 bacterial vaginosis, bacterial lactobacillus morphotype, that is score is of 4. So in Gardnerella morphotypes, if more than 30 is 4, 5 to 30 is 3, 1 to 4 is 2, and less than 1 is 1, and 0 is 0. Mobilincus morphotypes is more than 5 is 2, 1 to 4 is 1, and it is 0 is 0. Interpretation: score is 0 to 3, 4 to 6, and 7 to 10. When you will call as a bacterial vaginosis if the score is 7 to 10. Okay. What is candidiasis? Candida species are normal flora of the skin and the vagina. Vulvovaginal candidiasis is caused by overgrowth of Candida albicans, basically Candida albicans and other non-albicans species. Yeast grows as an oval budding yeast cells or as a chain of cells, that is pseudohive. The symptomatic clinical infections occur with excessive growth of yeast. Disruption of normal vagina ecology or host immunity can predispose to vaginal yeast infections. Clinical presentation of vulvovaginal candidiasis: it will usually present vulvar pruritus, thick white cuddy vaginal discharge, that is look like a cottage cheese like appearance. There will be erythema, there will be irritation, occasional erythematous satellite lesion also you find, external dysuria and dyspareunia. Diagnosis, history and signs and symptoms: visualization of pseudohyphae, mycelia and or budding is conidia on KOH or saline wet preparation. You get a pseudohyphae or mycelia or budding is on KOH or saline wet preparations. pH normal is 4 to 4.5. In normal vaginal pH 4 to 4.5, that is acidic pH. If it is candidiasis, the pH is more than 4.5, consider concurrent bacterial vaginosis. No, in candidiasis pH would be like normal vaginal pH, because candida usually resistant to acidic environment, so pH will be normally in candidiasis. And if pH is more than 4.5 with candida infection, you should suspect other concurrent trichomoniasis and bacterial vaginosis also. Culture not usually routinely used for diagnosis. The classification of the vulvovaginal candidiasis, it will be uncomplicated vulvovaginal candidiasis, and it could be a complicated vulvovaginal candidiasis. Uncomplicated usually sporadic, there are infrequent vulvovaginal candidiasis, mild to moderate VVC, likely to be due to candida albicans. And the uncomplicated usually occur in non-immunocompromised. Those don't have immunocompromised state, those patients they have complicated VBC, recurrent vulvovaginal candidiasis. These usually recurrent, these usually severe type of VBC. These usually occur by non-albicans candidiasis. This usually associated with those patients with immunosuppression like uncontrolled diabetes, HIV, or any other steroid use, prolonged steroid use, immunomodulator use. This is trichomonas vaginalis clinical presentation. Okay, let's talk. Clinical presentation of trichomoniasis may be asymptomatic 70%. Vaginitis from frothy gray or yellow green vaginal discharge. Pruritus, cervical petechiae, strawberry cervix. Classical presentation occurring in less than 2% of cases. Associated with increased shedding of HIV in HIV infected women. Diagnosis: how will diagnose? Motile trichomonas seen on the saline wet mouth. Vaginal pH is more than 4.5, often present. Culture has been the gold standard for for diagnosis. DNA probe test, rapid test, antigen detection test, nucleic acid amplification test, urine or vaginal swab you can take. The recommended treatment for bacterial vaginosis: you can give a metronidazole 500 mg orally 2 times daily for 7 days, or you can give a metronidazole gel 0.75% on full applicator 5 gram intravaginally once a daily for 5 days, or you can get clindamycin 2% on full applicator of 5 gram intravaginally at a bedtime for 7 days. Alternative regimen: clindamycin 300 mg orally 2 times per day for 7 days, clindamycin ovules 100 mg intravaginally once at bedtime for 3 days, secnidazole 2 gram oral granule in single dose, trinidazole 2 gram oral single once daily for 2 days. Clindamycin ovule use an oleaginous base that might weak latex or rubber product, condom and diaphragm. So use of such product within 72 hours after treatment with clindamycin ovule is not recommended. So don't use because it rupture condom and diaphragm. Don't use condom and diaphragm if the patient has already used clindamycin in last 3 days. Oral granules should be sprinkled onto one sweetened applies yogurt pudding before the injection. A glass of water can be taken after administration of adding solid. Then trichomoniasis, the recommended regimen for the trichomoniasis among the women: metronidazole 500 mg BD for 7 days. Recommended regimen taken among men is metronidazole 2 gram orally only single dose. Alternative regimen for women and men: trinidazole 2 gram oral single dose. Recommended regimen trichomoniasis HIV infection: metronidazole 500 mg BD for 7 days. CDC 2021 guidelines: vulvovaginitis, candidiasis, clotrimazole 1% cream 5% intravaginal daily for 7 to 14 days. Clotrimazole 2% cream 5 gram intravaginal daily for 3 days. Miconazole 2% cream 5 gram intravaginally daily for 7 days, or you can give a miconazole of 4% for 3 days. Miconazole 100 mg vaginal suppository 1 suppository daily for 7 days. Miconazole 200 mg vaginal suppository 1 suppository for 3 days. Tioconazole 6.5 is ointment 5 gram intravaginal single applications. Butoconazole single dose bioadhesive products intravaginal single dose. Teroconazole and fluconazole single dose. Okay. The recurrent VDC 7 to 14 days topical therapy. Initial, if it is a recurrent vulvovaginal candidiasis, 7 to 14 days of topical therapies, or you can give a systematic therapy 100 mg or 150 mg or 200 mg dose of oral fluconazole every 3rd days for a total 3 days, day 1, day 4, day 7. Then you give a maintenance therapy oral fluconazole 100 mg or 150 or 200 mg every weekly for 6 months. 30 to 50% will have a recurrent disease after maintenance therapy is discontinued. Persistent recurrent trichomoniasis, single dose therapy should be avoided. For treating recurrent trichomoniasis, it should be metronidazole 500 mg orally twice daily for 7 days. If fails, metronidazole 10 2 gram orally daily for 7 days. Alternative regimen: intravaginal paramomycin plus high dose of tinidazole, or intravaginal boric acid plus nitazoxanide. Recurrent bacterial vaginosis, after first recurrence, retreatment with same regimen. Use a different recommended regimen. Multiple recurrence, metronidazole gel 0.75 twice weekly for 4 to 6 months. Remember this recurrent bacterial vaginosis, the dose and duration is different. Metronidazole 0.75% twice weekly for 4 to 6 months. Or a metronidazole tablet if you are taking, then 500 mg twice daily for 7 days, followed by intravaginal boric acid 600 mg daily for 21 days, and then metronidazole gel 0.75% twice weekly for 4 to 6 months. Very important. Multiple recurrence cases, monthly oral metronidazole 2 gram plus fluconazole 150 mg you can give. European guideline management vaginal discharge, adjuvant vaginal application of probiotic were effective in preventing recurrence over a 6-month period. Probiotic, vaginal application of probiotic. So how will differentiate all these bacterial vaginosis and candidiasis and trichomoniasis and normal bacterial vaginal flora? Symptom of presentation, bacterial vaginosis, odor, discharge and itching, and candidiasis बहुत ही itchy होता है, discomfort, dysuria, thick discharge. In trichomoniasis, itch, discharge 70% will be asymptomatic. The vaginal discharge is clear to white, homogeneous. In bacterial vaginosis, this homogeneous, adult, thin, milky, white, malodorous, foul, species, thick, clumpy, white, cutaceous appearance, frothy, grey or yellow-green malodorous. Clinical finding: the inflammation and erythema, cervical inflammation and erythema seen in candidiasis, trichomoniasis, cervical petechiae and strawberry cervix. The vaginal pH will be more than 4.5 in bacterial vaginosis. Candidiasis is usually less than or equal to 4.5. Trichomoniasis is more than 4.5. KOH 50 is negative. Bacterial vaginosis is positive and trichomoniasis is positive. In candidiasis, KOH 50 is negative. NaCl wet mount, lactobacillus is a normal flora. Bacterial vaginosis clue more than 20%. Few RBC, WBC, few to many WBC, motile flagellated protozoa in trichomoniasis, many WBC, KOH bound pseudohyphae or spore if non-albicans species will found.